I really thank the organizing committee for giving me this wonderful topic, viral hepatitis, hepatocarcinogenesis, light of care. So basically, I think I can talk about anything I want to talk because this is such a undefined topic. So anyway, I'm going to focus on what we've been doing in the past 30 years. So we know that hepatitis B causes chronic hepatitis, and then called liver cirrhosis, hepatocarcinoma, and then we invent antiviral therapy, and we invent vaccine to lower down that incidence of hepatocarcinoma. However, as other human intervention of the disease, there's always some drawback. So for viral and antiviral and vaccine, we know that there's going to be mutant got selected. So our question we want to ask is that whether the mutant got selected, will it be more toxic or more oncogenic compared to the wild type? If some of them are like that, then it's going to drag down the effect of the anti-cancer that we've been working on by vaccine and antiviral therapy. So that's the whole logic we wanted to study. So in the early years of our study, we focused on one very interesting immunity-resistant mutant. It's in reverse transcripted 181, and simultaneously it has a stop codon and surface antigen, because we know that the two genes are overlapped. And later we found that actually after the immunity treatment, there are not just this point, there are multiple point mutations that all cause a surface antigen truncation. So, and some of them we have shown that it can increase oncogenesis using the mouse model. But fortunately, not a few years later, we already have entecavir and tenofovir. They can rescue this problem. Then before that, we also found that adefovir, interferon, and vaccination, they all can generate this kind of truncation mutation. So even though we have entecavir, tenofovir that had remedied this problem, but there is still some small trouble remaining there. That's the chromosome integration of HBV mutant. I'm going to show you in a moment. So this is unpublished data. This is the patient that had received lamivudine treatment, and later he received he shipped to entecavir treatment, and later he developed carcinoma. So because it's been constantly followed up, so we can gather liver tissue through their surgical sample, and we do next generation sequence. The tumor and non-tumor part, they don't have cccDNA. However, they do have HBV RNA. And now you can see that in the non-tumor part, HBV RNA, there are multiple points of the surface truncation. They've been shown in red point. And in the tumor, HBV RNA is the one that is in lower percentage is 182. It becomes a very high percentage, so it got enriched. So although there are many other possible explanations, my interpretation is that these RNA probably coming from integrated HBV genome that has been developed during the lamivudine treatment. So during the lamivudine treatment, that truncation mutation developed, and then the genome got integrated in the chromosome. And even though we shipped to entecavir, that integrated HBV DNA is still generate RNA, and one of the mutations probably contribute more to the oncogenesis, and then got enriched in the tumor part. So that's my interpretation. But of course, you can reach your own interpretation because this is only one patient's data. But in the other patient, it is just being treated by entecavir, but not being treated by lamivudine, and later developed carcinoma. You can see that there are no signature of this kind of surface truncation mutation. Okay, then we do have transgenic mice model to show that this kind of mutation, that if you have a higher expression or lower expression, it can cause transgenic mice hepatocarcinoma compared to the wild type. It's not. And when you look at the mechanism, it's not related to ER stress, it's related to a tumor suppressor gene. Okay, so now I'm going to turn to another topic, that's the vaccination. So here we asked, we know that in the previous talk, you already know that Taiwan is a very good, they perform a very good universal vaccination program. So after universal vaccination, the carrier rate is of surface antigen already below 1%. However, there's one question that people haven't asked, is that what about the occult B infection? Now, the reason we're asking this is that after neonatal vaccination, when you want to check HPV carrier, you usually just check surface antigen. So the only way you can know that it's an HPV carrier is that you check S antigen. But how about occult B infection? Because we know that occult B infection is there. But then, unless you do DNA testing, otherwise you won't know there's a occult B infection. So fortunately, we got from the government, they give us over 1,000 sample. These samples coming from the people that already received neonatal vaccination. And these people, this serum sample come from young adults. So after they receive neonatal vaccination and they become young adults, they give the sample. And then we do DNA testing for all these samples. So what we found is that we do find 5% of the patients have occult B infection. So even though you got HPV vaccination, neonatal vaccination, but in a society that has so many HPV carrier, you still have a percentage. Here we see 5% of the patients that have occult B infection. And if you sequence that patient, you can see that they have mutation, either surface truncation or they have mutation in A-determinant. That's like vaccine escape mutation. So this study is done in 10 years ago. So at that time, these are young adults. Now, we're thinking that, okay, these young adults are going to grow up. And when they grow up, half of them will become mother. Their mother will carry the occult B infection, where they transmit to their infant. So 10 years later, Dr. Lai conducted very carefully this study that she's do DNA testing for pregnant mother. So I think it's probably more than 100 of pregnant mother to see whether they have occult B infection. So again, she saw there's still 5% of the mother have occult B infection. Now this mother is pregnant, so she's going to deliver a baby. So we can now ask whether the occult B infection can transmit it to the baby. So what she saw is that of 10 pairs of mother-infant pair, 4 of the infant either become surface antigen positive or HPV DNA positive when they are delivered on their birth. So it seems that this occult B infection can transmit to the infant. Now remember, this occult B infection is the virus that's been developed after neonatal vaccination. So it's kind of the vaccine escape mutant. Now this vaccine escape mutant has been transmitted to the infant. Now the infant in Taiwan, everybody received neonatal vaccination for 3 doses. So if whether these neonatal vaccination can prevent this occult B infected infant to become chronic, that will be a problem. Because if it is become chronic, then although we have surface antigen negative, but we still have DNA keep going on generation after generation. That's the point that we are worried about. Fortunately, after 1 year, because every child in 1 year is going to check surface antigen again. So this child, even though at birth they have surface antigen positive or DNA positive, after 1 year they all become negative. So that's a good news. So it means that even though we have occult B infection, 5% in mother, that is our next generation. But in our grandson generation, it's not going to be lost. So it's going to be disappeared, even though its occult infection is still there. Now, even though it's good news, there's still, again, there's a small trouble hanging there that I still don't know whether it will cause any more problem. That's the integration problem. Now, if you look at the AALSD positive mother, if you do the sequence, you can see that there's still surface negative, surface truncation mutation over there. And there are some of them, of course, it's like vaccine escape mutation over there. Remember that 10 years ago is 5%. Last year is also 5%. So that 5% of AALSD infection has been there for over 10 years. Now, some of them is going to be integrated into the chromosome. So where it causes trouble, like what I have just shown you, that where it causes trouble, that it become the RNA still get transcribed, translate, and then it causes hepatocarcinoma. So what, we don't know, but that's something we have to look at. So because it's carcinogenesis, so we know that, so I put this slide here, so we know that in the surface antigen, the surface truncation and or X wild type mutant, they can cause the so-called ER stress independent pathway. Now remember that there is large surface antigen that's been proposed by Francis Cesari. The large surface antigen, if it is in a large amount, it can go through an ER stress dependent pathway to cause cancer. Now the reason I'm showing this is because you know that the protein has a very large amount of surface antigen comparing to all the other proteins, so this is a more attractive model for hepatocarcinogenesis. Now, of course, there are other mechanisms like integration, or the host factor, or the hepatocyte proliferation factor, and causing the genetic host mutation. These are all possible factors for hepatocarcinogenesis. Okay, so now turn to the next page. So after the entecavir being available, now people like to cite this Dr. Kosaka's study, that after entecavir being available, you can see the cirrhosis mutation. If you treat it by entecavir, the HCC just reduced significantly. But what catch my eye is that even though the patient received entecavir treatment, they still have 3.7% of the patients that get hepatocarcinoma. So for a very long time, I think it's probably the microenvironment factor. They haven't seen whether there are other viral factors that's causing this until this study was conducted by Levin in our center. That what he did is that after the patient treated by entecavir, and then they develop hepatocarcinoma, just like these patients, and he sequenced the virus from this time point, and what he found is that, yes, in the preliminary region, there's no mutation at all, but then he sequenced the X region, because the X region is something to do with hepatocarcinogenesis, and what he found is that there is some weird mutation in the X region being developed. So he go ahead to show that in the cell model, these mutations can cause, is more oncogenic compared to the wild type, but that's the cell model. We still don't have the animal model. Now what's interesting is that one of the mutations, when we look at more patients' data, after entecavir treatment, the incidence, the prevalence of this X mutation is going to increase. So this has not been published yet. But then, so it's telling us that one of the X mutation can be enriched by entecavir treatment. So we then conduct this study. This is called suboptimal virological response. Now, when we start antiviral treatment, you know, some of the patients, their DNA will not completely disappear within a very short time. Some of them, the DNA will persist for a long time, although it's very low. And some of them are still there, even though after 1 or 2 years it's been there. It's called suboptimal response. Now, you look at all the guidelines like ASOD or ESO or TASL, definitions are all different. What's the suboptimal response? The definition is different. Now, and the management suggestion is also different. Now, so what we can see here is that if you define that as a 6 month, that DNA is still there, then it's a very independent factor for the risk of hepatocarcinoma. which means that if you don't suppress the virus immediately, not immediately, within 6 months, then it's going to be an independent risk to develop hepatocellular carcinoma. So I think, okay, so and later, they try to understand why this kind of phenomenon could occur. So what he found is that these integrally treated patients that have suboptimal response, actually they have a whole bunch of X gene mutation. And what these X gene mutations done is that it can increase the cellular cccDNA. So think about it, it increases the cccDNA in the patient, so the patient will not respond very well to your antiviral treatment. So your antiviral treatment will become suboptimal. There will always some low-level virus there. Okay, so how can we solve this problem? Actually, it's very easy. You just avoid suboptimal response. So in ESOL guideline, they suggest you, if you have suboptimal response, they suggest you to add another drug or shift to another drug, just kill all the virus. Not kill, just suppress all virus till undetectable. But in ASL or TASL, we don't have this kind of guideline. Okay. So, so it is the only way that to deal with suboptimal response. Now, Dr. Liao in our centers, my mentor, he proposed another way that you simply don't just remove that drug, just withdraw that drug, and let the exacerbation happen under your observation, under your monitoring. Okay, so you're in Taiwan, we practice the finite treatment. So after you treat it for a period of time, you just withdraw the drug and let exacerbation happen under your monitoring. So if you do that, you can see that the surface antigen seroconversion is going to increase. And then this year, Dr. Zheng have found that hepatocellular carcinoma risk is going to decrease if you make the drug withdrawal. HBsAg loss will increase, and this will decrease. Now, of course, there is some other explanation for this, and we still don't know what's causing this. But then, one of the explanations that we know that after you withdraw the drug, the immune system is going to come back, and the wild type is going to take over of the mutant. That's what has been reported in other previous studies. So you can see that if that X mutant hypothesis is right, then if you withdraw the drug, instead of completely suppress the virus, if you withdraw the drug, you can still get the same effect, that you can eliminate that mutant. Maybe that's why HCC will reduce. I don't know, this probably there's something else we don't know yet. But if you want to practice it, you still have to be very careful, because if we withdraw the drug, it's going to have an exacerbation. So you have to monitor the patient very carefully. You want this kind of beneficial effect to get it. Okay. So I'm going to give you a summary. So some of the antiviral vaccination-related HBV pre-SS truncation mutant have increased oncogenicity. So I think this is something that will track down the effect of our vaccine or antiviral therapy. And then although the entecavir or tenofovir have been developed, they can remedy this problem. However, we know that the integrated HBV DNA from previous treatment, like in Taiwan, we have many community treated patients, and many of them, I believe, their integrated DNA is there. This is, I think, is going to continue to cause you the problem. Okay, and then for the vaccination, we know that there are 5% of the patient, our children generation. Although if you look at the surface antigen, it's below 1% at vaccine escape. But if you do a DNA testing, it's going to be 5%. So these 5% of the cause B infection. Now we know that if this mother, it will transmit to the infant. The infant is not going to lose. The infection is going to be lost of the neonatal vaccination. So our grandchildren generation probably okay, but our children generation, CoV infection, 5% there, I think it's going to cause you some problem. Although we still don't know what kind of problem. one thing is I can imagine is that if the patient has to receive immune suppression or chemotherapy, it's going to cause you a problem. So that's something we have to look at. What else? So we know that antibiotic treatment with suboptimal response is going to give you some problems. So either you completely suppress that till complete zero. Otherwise, maybe you want to try to withdraw the drug and let the immune system take over. Just carefully monitor it. Okay, now of course, like Dr. Terrell had just said, that if you have a complete cure of hepatitis B, then you don't have to worry about the strategy. You just cure the virus like hepatitis C, then you'll be okay. But now we don't have that complete cure. So there are so many problems that's troubling us. So we have all kinds of different opinions, all kinds of debate. Thank you. That's the last slide. I want to thank my advisor, my PhD advisor, Jim Mo. You probably know him. Jim Mo, and my mentor, Dr. Liao, and my another advisor, Dr. Chen, is also. They are all helping me to do all this research. Thank you for your attention.